go straight away to the cases. Shruti Kotputo, Nimanma.
I think he's got unmuted. Kushal? We can't hear you on the system. Okay. Shall I start the session, Ravishankar? I think Kushal is having tech issues with his voice. Kushal, can you speak? Kushal? Okay.
Yeah, please go ahead and straight away give to Shruti. I think time is up.
Good evening and a very warm welcome to all the participants of this wonderful K Samanvay program. This is our bi-monthly webinar series wherein we attempt to bring forth the subspecialties with cases which are of interest to the general practicing pediatricians. Today we have a wonderful lineup of faculty who will be deliberating on a common symptom which we encounter in our practice, that is the chronic pain abdomen. Before we introduce our speakers for this evening, a warm welcome to all, to the President IIP Karnataka, Dr. Ravishankar sir, our National President 2024, Dr. G.V. Basaraj, who has also joined in, requesting Dr. Ravishankar for his opening remarks.
Yeah, I think we can straight away go. Already it is late. So anyhow, I welcome everybody to this Samanvay, where we discuss each other about the cases we are facing in our day-to-day practice. So abdominal pain, we know all of us who are all practicing, at least one case will be there. Out of 1% of the cases will be abdominal pain. So especially the child going in the early morning to the school tells mummy pain. So always the parents get anxious. What exactly is happening with my child? So many investigations will be done, ultrasound, blah, blah, so many other things will be done. Ultimately will come nothing. And once again, we tell just an assurance. So this is what is happening to us. So let us discuss how many are really benign, how many are really such serious cases. So it is left to the gastroenterologist. We have got here Dr. Agenda, Vishnu, Nirmala ma'am and others here and to discuss about those things. So hand over, I think Shruti can take over now.
Thank you, Dr. Ravishankar. Dr. Kushal, are you available?
Madam. Yes, madam. Yes, madam.
Yes.
Now I would like to ask our coordinator, Dr. Nandish, to give the opening comments.
Yeah, very good evening all. IIP Karnataka, under the esteemed leadership of Dr. Ravishankar, President Sir, is having this program. We are very thankful to our chief guest, Dr. Nirmala Madam, today, and our expert, Dr. Malati Satya Sekharan, and our speaker, Dr. Nagendra Kumar and Vishnu Biradar, our friend. With all these great esteemed faculties, no doubt we are giving the best academics possible through IIP Karnataka, and we thank all the delegates who have joined today for this excellent academic session which will be going to be. We thank all of this. Let's
thank you very much,
into
sir.
the academics now.
Thank you very much, sir. Now I'd like to ask our past president, Dr. G.V. Basaraj, to give comments.
Illa sir, illa ansutte.
Now I would like to ask Dr. Sumita Nayak, our Vice President, Karnataka IAP, to introduce our speakers, guests and our speakers.
Thank you, Dr. Kushal. It's an honor for me to introduce our chief guest for this evening, Dr. Nirmala, who is the president of the ISPGAN for the years 2026 and 2027. Thank you, ma'am, for accepting our invitation to be with us this evening. Ma'am is the ex-professor and HOD of gastroenterology at ICH and HC Egmore, Chennai, and a consultant pediatric gastroenterologist at Vijaya Hospitals, Chennai. Ma'am, thank you once again for being the chief guest this evening. We would like to hear a few words from you before we jump into the session this evening.
Good evening all. Thank you so much, Dr. Sumita and Dr. Nagendra, for bringing me here today. And this is the first time I am attending this 9 o'clock session. I've never attended all these sessions all these days. Quite interesting timing. And then I think this is a good initiative that you're having, that subspecialty case discussions twice a month, which be used for all the pediatricians, the youngsters also. And it's a very good topic. Abdominal pain, as you said, it's a very, very common topic. Very, at least 10 to 20% of our usual practice will be abdominal pain, and it's always a headache. Most of the time, we'll not be, as you said, we'll not be able to find out the cause. And but anyway, we have to have certain clues to get the organic and from the non-organic causes. And nowadays, even functional abdominal pain is a positive diagnosis. No more diagnosis after excluding other causes. It's a positive diagnosis nowadays. Unless we have alarm, generally you can diagnose functional abdominal pain otherwise also. So, I think this is a good topic, and we have very, very two good, very speakers of our Ispagan fraternity, Dr. Nagendra and Dr. Vishnu. Both of them are very good friends, and I think they will take us through their cases, through their history, to decipher the various causes of abdominal pain. Thank you.
Thank you so much, ma'am. That's really inspiring words from you. I now call upon Dr. Shruti. Shruti, please take over the proceedings of this evening.
Thank you, ma'am. Good evening, one and all. It is my pleasure to introduce the expert for today's topic, that is Dr. Malati Satyashekaran. She is a senior consultant pediatric gastroenterologist at MGM, Rainbow, and Kanchi Kamakoti Child Trust Hospitals in Chennai. Ma'am completed her DM Gastro in 1986. She is a great teacher. We know her as a great teacher, and she is a teacher for MD Pediatrics and also for DM Gastro students. And she has nearly 78 publications. She's an author for nearly 25 chapters. And she was the past president of Ispagan, that is 2018-2019. And has delivered many guest lectures and orations. Dr. Malati Satyashekaran, may I request you to speak few words, please?
Thank you, Dr. Shruti. Thank you, Dr. Ravishankara, and all of you, this team who has starting this another session at 9 p.m. So I always appreciate when you all like to know about other specialties, and you seem to know more about so many specialties. We are all concentrated into one, but really appreciate your enthusiasm, your passion to learn. And it gives me a joy to be here. Like Dr. Nirmala was saying, that this team, you'll have two wonderful speakers, excellent, Vishnu as well as Nagendra, who will really bring to you the problem in their cases. And I don't want to stand between you and the speakers. I think we should just start, and so that we have more time for interaction. Thank you once again for inviting me for this session. Thank you so much.
Thank you, ma'am. Thank you for the encouraging words. I would like to quickly introduce our two speakers for today's session. We have Dr. Vishnu Biradar, who's done his fellowship in pediatric liver transplant in UK. He's a consultant pediatric gastroenterologist and hepatologist in Pune. Dr. Vishnu has won multiple awards like the Espegan International Travel Exchange Award in 2018-19 and the Young Invigilator Award. And Sir has presented more than 10 papers and has also been the author for 5 book chapters. We welcome you, Dr. Vishnu Biradar. Thank you for joining us here.
Thank you for the kind words.
Vishnu, you can share it. I've allowed everybody to share the thing.
Okay.
I think you no need to go become a co-host. You can share it. Just try it.
I would like to introduce our next speaker, that is Dr. Nagendra Kumar. Dr. Nagendra Kumar has done his DM Pediatric Gastroenterology from SGPGI, Lucknow. He's currently the lead consultant of Department of Pediatric Gastroenterology at Rainbow Hospital, Bangalore, and is also a consultant at Indira Gandhi Institute of Child Health. He has presented multiple papers and is involved in teaching modules, national guidelines, textbook chapters, and is also a speaker at multiple national CMEs. We welcome you, Dr. Nagendra, for this session.
Thank you, Shruti. Thanks for those kind introduction.
Yes, sir. Ravishankara, sir, I can share it. I just
I know. I saw it. Yeah.
Thank you.
I think everyone are eagerly waiting to start the case presentations. Can we start off the session, Dr. Nagendra?
Yeah. Thank you very much. Good evening, all. At an outset, I would thank K. Samanvai team, Dr. Sumita, Dr. Ravishankar, and everyone. Thank you very much. So straight away, I'll get into topic because there is not much time. So now, why we chose this topic is it's extremely common
Full
and
screen ಮಾಡಿ ನಾಗೇಂದ್ರ. Okay.
it's extremely common and it's extremely distressing and it takes a lot of time in your OPD. So basically, many of the times I'll become like this because a lot of my practice goes into chronic pain abdomen and kids are funny. They will be crying for a minute and they will be enjoying for a minute around. And then parents are of course unhappy, goes around doctors, one after the another. They won't be happy because child will be always fun. So why it is important for you and as well as for me is in any pediatric office practice, 2 to 4% you'll see at least this problem. Maybe urban and private clinics would have much more than rural clinics. And then pediatric GI practice, as Nirmala ma'am said, it is 25 to 30%. And most of them, again, it depends on where you are practicing. If I'm sitting at Indira Gandhi, maybe I find more organic causes. If I'm sitting at the private clinic, then more functional causes. So you all know abdomen is a Pandora's box. On the top of it, pain abdomen is a super symptom. I'll call vomiting and pain abdomen as a super symptom because the causes can be innumerable, multiple. Each organ can lead to pain abdomen, including there are few organs which are not even in the abdomen can lead to stomach pain. So that's why I always call pain abdomen as a super symptom. You see, it is so difficult to find when your practice has 95% functional to find one organic among them. It becomes very difficulty and it will be added responsibility to pediatric gastroenterologist while pediatrician has trusted us and referred the case. So now, chronic pain abdomen, by definition, it is interchangeably, we always say it is as a functional pain. So basically, when the pain is recurrent and persistent, then we call it as, and duration is very difficult to say. Few literature, few papers have mentioned 2 months, few are 3 months. So it is more of a clinical decision and it is most of the times refers to functional GI disorder and the latest terminology is disorder of gut-brain axis. Just telling this word gut-brain axis will give a lot of pathophysiological basis. So now there are a lot of causes for chronic pain abdomen. Only few common causes I have mentioned based on the age and age becomes very important. Functional, there is a host of list of functional GI disorders in less than 5 years. Most common being infant colic, dyschezia, constipation, and organic are allergies, then choledochal cyst, intussusception, malrotation. Then school-going children can have otherwise functional abdominal pain not otherwise specified, along with abdominal migraine and dyspepsia. And the organic causes are like inflammatory bowel disease or some sort of peptic ulcer disease, choledochal cyst, diverticulitis, pancreatitis, hepatitis, all these things can be there. And in adolescents, again, they can have irritable bowel syndrome or functional dyspepsia. These two are quite common in them. And then again, organic will be IBD, tuberculosis, peptic ulcer disease, gynecological issues, vasculitis, gallstones, renal issues, all these things can be there. The list is quite exhaustive. And then there are some pointers which suggest organic and functional. So the most important is looking at the red flags. So I'll just take one minute, I mean, at least half a minute for each of them. So if you say the pain is very early onset, like 1 month, 6 months, so generally you should always think about organic apart from infantile colic or dyschezia. If there are constitutional symptoms like weight loss, fever, think about something abnormal. If there is associated GI bleeding, think about organic cause. Persistent vomiting is very important. Pain is referred to back or radiating to back or radiating to inner part of thighs. Think about organic causes. associated with diarrhea. That is also one more important. Nocturnal pain abdomen, very, very important symptom. If something is causing nocturnal pain abdomen, don't just think that this is functional. If there is associated
Nagendra,
urinary symptoms,
Nagendra, I'm Dr. Ravishankar here.
yes,
I
sir.
will be muting all, including you also, you will get muted. So please
Okay,
immediately unmute yourself because a lot of disturbance are there.
okay, okay.
Okay, now you unmute yourself. Yeah.
Okay.
Okay.
Okay. And one more thing is whenever the pain is far from the umbilicus, I mean belly button, think about organic, just don't think about functional. So what about examination? Abdominal distension. If there is abdominal distension along with the pain, think about organic always. It can be gaseous, it can be organomegaly, it can be some fluid. So always think about that. Very localized pain. I mean, very well localized. I know that less than 5 years, it is children find it very difficult to localize. But if there is guarding and rigidity, tenderness sometimes they do complain, but if you divert their attention, you may not see that tenderness thing. So but if there is a guarding and rigidity, then definitely you are dealing with some organic cause. If there are other symptoms like arthritis, faltering growth, jaundice, or perianal disease are associated with organomegaly, mass, then definitely you are thinking about something organic. And when it comes to baseline investigations, if you think that yes, there is something abnormal, as Dr. Nirmala said, this is positive diagnosis. It does not need that you have to do battery of all tests before saying this is functional pain. So basically, you need to see blood abnormalities. Hypoalbuminemia is always suggests that there is some problem. Elevated inflammatory markers, very, very important. And fecal occult blood. Celiac somehow South India it is quite less, but you have to see because Bangalore is a metropolitan city. You will see a lot of North Indians and other inter-region marriages, elevated amylase lipase and abnormal LFT. So just with these tests, I think 99% of the causes you will cover. Extremely rare, maybe missed, but most of the times, if you are doing these many tests, you are checking all the boxes. So with this brief introduction, I'll go to two cases. Basically, what I want to emphasize is how these cases present like functional, but actually they have underlying organic causes. So I saw recently 1 month back, 7 years girl with recurrent episodes of pain. So they were discrete episodes with mild to severe pain, epigastrium, non-radiating or referred, but that was associated with vomiting and many times associated nausea. And after vomiting, child used to get better. There were no other constitutional symptoms. Generally, these episodes last for 1 to 2 days. They generally go to the nearby pediatrician. Most of the times food poisoning or gastritis, PPIs are given, ondansetron given. Sometimes even they received IV PPIs and ondansetron and maybe some constipation, laxatives. Child is okay, then going back home and again similar episodes. So on examination when they came after 2 years of pain, so weight was affected, third centile, rest all were okay at that point of time. In the past, multiple blood counts were done, LFTs were done, CRP was done, RFT, serum electrolytes, everything were normal. Ultrasound abdomen also was done twice, which was normal. So now, this can be functional pain or functional disorder otherwise, but there is associated vomiting and child required intravenous medications to control the symptoms. That suggests this is definitely this may be organic. So there are some functional conditions which can behave like this also, but still it can be organic. So what are the differentials when you look into functional causes? It can be abdominal migraine because nausea, vomiting, stomach pain, all these were there, and it's a epigastric pain, midline pain, or it can be cyclical vomiting because child had multiple episodes of vomiting, or it can be organic cause because it's a epigastric pain. It can be some sort of biliary, hepatobiliary cause, chronic pancreatitis, gastritis, peptic ulcer disease, secondary to H. pylori. So all these were considered. So then next step, what I did was to get a ultrasound abdomen. But this time I just called up the radiologist and asked, especially look into pancreas, biliary system, and SMA, SMV axis. for malrotation. So actually here you can see the pancreas was quite atrophic. You can see the rim of the pancreas. It is not a normal pancreas, how it looks like. Here also you can see some atrophy of the pancreas. This is liver. And then you can see this duct. See, this duct is generally 4 millimeter in the head. In the adults, in children it may be around 3 millimeter. Here it is almost 7.2 millimeter, which is quite huge for normal pancreas. So definitely there is some underlying pancreatitis. On ultrasound, the calculus was not visualized. Next day, again, child had a severe pain, vomiting. So I had suggested to get serum amylase lipase. You can see it is quite high, suggesting there is acute and chronic pancreatitis. So we did MRI with MRCP. Sir, can you mute? Chandrasekhar, sir.
Nagesh, you unmute yourself. Nagendra, unmute. Nagendra, you unmute. Nagendra. Now you speak.
Okay. So again, MRI, you can see very hugely dilated duct, and there was a stone which was impacting in the head of the pancreas, so causing upstream dilatation. So that's why this child was having constant pain, and she was unable to get relieved. ERCP, definitely we did major papilla sphincterotomy, and then we broke the calculi and cleared the duct. Post clearing, we placed the plastic stent. Child is okay now. So basically, this is a case of chronic pancreatitis, which was just getting treated for last 2 years, has recurrent pain or recurrent gastritis. So proper evaluation showed that this is actually a chronic pancreatitis. So you should have a high index of suspicion to diagnose chronic pancreatitis. Many times your amylase lipase may come normal because they don't have enough pancreatic mass. And most of the times they have a neuropathic pain secondary to chronic pancreatitis. So don't think that just normal amylase lipase rule out chronic pancreatitis. Sometimes it may be elevated, sometimes it may not be elevated. Radiologically, you should do ultrasound. If required, you can do CT scan or MRI with MRCP if you want to see the ducts. Then endoscopic evaluation is ERCP, and some cases endoscopic ultrasound. And I found chronic pancreatitis most common cause, almost 90%, is due to genetic basis, or at least first it will be the genetic, second it may be something else. So basically whole exome sequencing may also be required. So how will you management? Pain management is very important because they'll get a pain due to blockage, ductal hypertension, or damage to the pancreatic parenchyma, or due to damage to the nerves. Then they may need endoscopic management like what you have seen in this case. Sometimes they may need surgical drainage, like lateral pancreaticojejunostomy, phrase, or even head coring procedures. Some of them have exocrine insufficiency because I have seen lot of kids were normal. They lost to follow up after 1 year. They presented with diabetic ketoacidosis. So endocrine insufficiency becomes very important. And on long run, they all end up in exocrine insufficiency where they need pancreatic enzyme replacement therapy. So basically, see in this child, even though some of the pediatricians got ultrasound done, but actually you should clinically suspect what you are, and sometimes you have to communicate with your colleagues that what exactly you want to see. And you need to analyze the pain based on their components, nature, severity, and think about organic or functional. Well-directed test and relevant clinical details need to be discussed with the colleagues, and clinical examination and clinical details becomes the key. So this is about the first case. Ma'am, you want to, Dr. Malti, you want to add anything in this case?
I think we'll just say 2 points with this. I think you've described a very important case of chronic abdominal pain, and beautifully you've given them, I think pediatricians, as you said, the chronic abdominal pain is very common. The first job is for them to try to differentiate between the organic and functional, because functional will be 80% of the cases and 15 to 20% will be organic, like you said. And they have to try to push it either into the organic or functional, depending upon either the red flag signs and symptoms, which may not be there. It is very difficult. But here there were some clues. I think the epigastric pain related to food. So usually how I teach is, first say chronic abdominal pain, that is very common. Second, look at the site of pain. Is it periumbilical? Is it epigastric or lower abdomen? Is it related to food, dyspepsia? Is it isolated or is it related to bowel habits? Then it is probably much little easier. And so when there is epigastric pain so severe with vomiting, attending hospitals, I think amylase lipase, if it had been done, yes, would have picked it up. Pancreas is a problem which may be missed on ultrasound. Ultrasound is not a very good test because it is behind the stomach and the stomach has to be filled and the person has to be, someone should tell if it's pancreatitis. If we tell them chronic, they may pick up, because chronic pancreatitis, it's not duration of the problem. It is the imaging changes by which we make. They are irreversible changes, either stricture, dilatation, stone should be there. I think the others, I think, once you make a diagnosis of chronic pancreatitis, the most common etiology in children may be genetic, it may be metabolic, it can be even trauma. But I think the management you've discussed. So for the pediatricians, amylase lipase to be done and try to exclude function. It is still difficult. Epigastric pain, will there be functional? Like you said, can be epigastric pain syndrome and it can be thing. Only thing is epigastric pain, severe. Nocturnal symptoms, we want you to say, did it awake the child from sleep, rather than saying nocturnal. And otherwise, all the others, you brought it out very beautifully. Usually abdominal migraine is usually periumbilical, and headache will be a very common feature, whereas cyclical vomiting syndrome, the terminology, stereotypical will be there. The mother will say the same symptoms are coming, doctor, the same symptom. That word stereotypical. I think with this, we can go to the next case. Unless someone has questions, we can finish this and go. Shruti, you want us to, let us go to the next case?
Yes, ma'am.
No, there are two questions are there, Shruti.
We'll take the questions in the end, no?
Kirti Kulkarni has asked her any history of fatty stools in this case. She has asked.
There was no history of fatty stools.
So this exocrine pancreatic insufficiency, doctor, usually comes when more than 90% of the pancreas is affected. The second one is the meal which they have taken should also contain fat enough to show the fat in the stool. But if you are in doubt, if the child is not gaining weight, you do the stool fat globules, which should be more than 50. But now we have, Dr. Nagadru will agree, we do the fecal elastase, sir.
Yes,
if it is less than 200 microgram per gram, then we know, yes, the patient child, that's what he's told about enzyme replacement therapy. We have to give them that. Chronic pancreatitis, PERT is very, very important, because the child will not gain weight otherwise if she's already got exocrine pancreatic insufficiency.
Yes.
Good. Now it is another common. Shashank has asked, how will a 6-month child will tell about the pain abdomen?
No, they won't tell, but the way the child cries, I think that's what doctors,
that
and
is the
usually
thing.
functional abdomen, I think he's beautifully said, less than 1 month to talk about, it's infantile colic only.
Yes.
Infantile colic is the one he's keeping in his mind as the functional GI disorder. Yes. So the way the colicky pain in a child crying, the mother will know the child has abdominal pain. And that is the thing. So it's not the child telling. Okay.
Again,
one more person,
symptoms becomes very important, sir. Associated symptoms.
Correct.
If there is some current jelly stools, or if there is a distension, vomiting, it's not just child crying.
Yeah. There is one more question from 1+. I don't know who is that. I would want to do EEG in such cases. Sometimes abdominal epilepsy also presents like this. Is it right?
No, epilepsy will have some other features. This type, when, please, all of you, very clear, epigastric pain related to food. Once you have a pain related to food, aggravated by food, please think of GI upper part of the abdomen. Epilepsy, they usually have some other features, either a loss, something vacant, headache. There are now good criteria under Rome 4 criteria for abdominal migraine, abdominal epilepsy, which should be taken. There'll be other things like light, when they look at TV for a long time, changing of that, change of colors, all that will be there. That will be a different type of presentation. The
Yes, madam.
DD for
Correct,
that will be abdominal migraine, isolated, what he said, functional abdominal pain, isolated. It's more a pain alone, that associated, that is what is very important, which Dr. Nagendra is saying. Associated symptom is very important. Vomiting with food, relieved after vomiting.
Yes.
Correct.
Yes,
I
yes.
think Nagendra, we can go ahead. I
Yeah,
think enough
actually, I
is
had some
yeah.
slides about it because lack of time, I'm just rushing on that.
Yeah.
So,
Please go to the next case.
yeah.
Yeah.
Next case is again a 13 years girl. So she came with 3 months is duration of pain. Pain abdomen, again, it was somewhere between periumbilical and hypogastrium. It used to increase after stools. So intermittently, this girl also had stools. Once she had loose stools, which were quite high. So she was given IV fluids, antibiotics, and otherwise she had some low-grade stools. Parents were extremely anxious. At 2 months of age, while investigating with one of pediatrician, so USG abdomen showed mesenteric lymph nodes. And after looking at even, I mean, they were not very big, but oral antibiotics were advised. So, but this pain abdomen was not improving. Otherwise, normal growth, no joint pains, no rash, no pallor, no edema, no hepatosplenomegaly. Stomach was very soft, non-tender, but she had some sort of urgency, frequency. I mean, she used to feel that she's still not completely evacuated. She used to go to toilets multiple times. So the hemoglobin was slightly low. She's adolescent girl who had her cycles recently, and then hemoglobin was 10. Platelets were 4 lakhs, not very high or not very low. Albumin was normal. Ultrasound was normal. Then CRP was mildly elevated, but to confuse me, there was some recent cough cold that this child had. Then amylase lipase were normal. Urine routine normal. Urine culture normal. So almost everything were normal except little bit high CRP and high ESR and mildly low hemoglobin. ESR high can also be explained by low hemoglobin. So now I have a 12-year girl, otherwise okay, pain abdomen, hypogastrium, episodic pain increases, change in stool consistency. When pain is more, the loose stools are also more, and relieves after defecation. Otherwise, no red flags clinically, but on investigation, I found that mild CRP was elevated. So now, differential diagnosis that was in mind was irritable bowel syndrome, or is it some sort of inflammatory bowel disease or genitourinary pathology? But all the urine and ultrasound, everything was normal. So now further evaluation, repeat ultrasound I did, again mesenteric lymph nodes, nothing I did. Then fecal calprotectin was high, 210. And with this calprotectin being 210 and this sense of urgency, frequency, and all these things, I wanted to scope the child. Upper GI endoscopy was normal. Colonoscopy, if you can appreciate, there were multiple small aphthous ulcers. These are like ulcers you see inside your oral cavity or lip. Similar aphthous ulcers were there throughout the colon, and there were some areas of skip lesion. CECT was normal. Histopathology showed faint granulomas with crypt distortion, which suggests there is a chronic inflammation. So with this histopathology and endoscopic findings, thought this is a mild to moderate Crohn's. There was no other history. So started on low dose steroids, azathioprine and 5-ASA. So this is a case which almost presented, I thought, like irritable bowel, but again, because there was high CRP, I did want to evaluate for inflammatory bowel disease. So again, they can present like abdominal pain, recurrent diarrhea, blood in stools, growth faltering, and extra gastrointestinal manifestations. Labs generally clinch the diagnosis of Crohn's disease and ulcerative colitis. Sometimes labs may miss, but fecal calprotectin and clinical blood in stools with sense of urgency, frequency, tenesmus clinch the diagnosis. So evaluation wise, apart from blood investigations, endoscopy becomes very, very important. OGD-scopy, ileocolonoscopy, enteroscopy also sometimes, capsule endoscopy, we have picked up many cases of Crohn's disease. Then radiologically, we do CT enterography, MR enterography. Remember, it's not simply plain CT or CT contrast CT. Please, if you are planning to do a CT scan, please do enterography or enteroclysis. Basically, it will distend the bowel loops, because many times they already would have got the CT, but not with the proper protocol, which makes us, it becomes very difficult to repeat the CT because of the radiation. And then histopathology is very important adjunct for the diagnosis. And of course, we have to do some microbiology to rule out mycobacterium, as we are from India. And tuberculosis, even now, 10 to 20% of cases in private sector and around 40 to 50% in public sector, I do see tubercular colitis. So management in nutshell is you need to give immunomodulators, both for, I mean, induction, we have steroids and TNF alpha inhibitors, biologics, and maintenance, we have antimetabolites like azathioprine, 6-MP and 5-ASA. And ulcerative colitis, if they present with acute severe or toxic megacolon, we may need colectomy. And in Crohn's disease, it's just more of just symptom relief. Like if there are complications, we do surgery to take out those complications, because surgery is not curative in Crohn's disease. So learning point from this case, at least what I got is, we can never be, when it comes to pain abdomen, we can never be relaxed, even though we know that when they enter, this looks like functional pain. There is, I mean, by appearance, there is nothing. But sometimes when you sit and talk, then you may think that no, this is actually not functional. There may be multiple things. So each and every symptom analysis becomes very important rather than jumping on investigations. And we have to spend time sometimes, otherwise we are going to miss, especially at the early stage. This child had just mild Crohn's. It would have been turned into severe Crohn's and complications later on. We don't know, but some phenotypes continue to be mild. But baseline investigations are again important, and proper planning of investigations are again important. So thank you very much. Malti ma'am, you can add some points.
Yeah.
whatever
Thank you so
feel.
much, Dr. Nagin. And I think you highlighted that for all the pediatricians, senior pediatricians, we are seeing more of IBD. So now we are tuned. Not that all pain abdomen is IBD, but he's given it very beautifully. The pain was lower abdomen, involved saying that it was, and also periumbilical. So he thought of bowel, and because it was related to altered bowel habits, and that fecal calprotectin, we don't use it for diagnosis, but sometimes we use it to defer a colonoscopy. Suppose it had come less than 50, Dr. Nagendra would have told the parent, just wait for some time, because that is a good important thing, though we don't do for all patients. So in our country, we charge 2,500. In abroad, the colonoscopy is too costly, so they use this as a screening. For us, colonoscopy itself is better. Why don't we see? But still, we do it for some time when this type of problem occurs. I think he will agree to that. And here, this child, it was good he did it. So he got the finding, he's got the granuloma, and he's now able to give a very specific treatment for the child. There may be pain even after that, but at least the parents will be happy. That anxiety will go. There will be an anxiety for the diagnosis, but at least a diagnosis has been made for the child, and he'll be able to tell. If there are some questions, we can take this. So the abdominal pain in IBD comes in Crohn's disease, even up to 40 to 50% can present only with abdominal pain, and may not have that characteristic thing. So, but here he got loose stools, but he looked at the full diagnosis. So stool occult blood was positive, Nagendra, for him?
No, ma'am. Stool occult blood, somehow I could not, the stool, what they got, test they got, it was negative.
Okay, so sometimes you may have to repeat, but stool occult blood positivity definitely tells there's a breach of mucosa. And imaging, what was done? CT abdomen not done.
CT abdomen done later on after colonoscopy.
Later on. So in children, we usually do, once we suspect IBD, we are supposed to do both endoscopy, lower colonoscopy, and small bowel study, either MR enterography or CT abdomen. If you have questions, we can take. Otherwise, so for you all, you will always be wondering, should we do fecal calprotectin in all children with abdominal pain if we suspect? Yes, you can do, not for the diagnosis. Just by doing fecal calprotectin, that will not exclude us from doing a colonoscopy. But suppose there's more features of functional, it is more looking like IBS, there's no weight loss, there's no other growth faltering, no occult blood positivity. Just to exclude, you may have to do, if it's less than 50, we can definitely avoid doing a colonoscopy.
And ma'am, one more thing I want to add, fecal calprotectin, when you look at the report, parents are definitely very much frightened because it is increases in cancers and everything. So I have seen so many patients, and I have seen sometimes acute pain abdomen or acute colitis. Some of colleagues have done fecal calprotectin, which has come to 20,000, 11,000 and all.
So that's nothing wrong. Testing, if there's blood in the stool, you may get it. One thing for the pediatricians, fecal calprotectin will not help us to differentiate between TB and IBD. It will not help us to differentiate between UC and Crohn's. But if you have extra intestinal manifestations alone in IBD, then it might give you a clue. This only way, if we do initially, is because it will defer a colonoscopy. Mesenteric adenitis, ultrasound finding in alternate reports, when should we treat? I think it is a little away from the routine. But mesenteric adenitis, you all know that it is an adenitis they call, but it's an adenopathy. Till the age of 10 years, it is very common. And by the age of 10 years, it comes down. Don't just look at the size, look at the number, look at the additional findings like thickened bowel loop, free fluid, and also constitutional symptoms. Everything should be looked at. Because you can pick up lymphoma, you can pick up, but all mesenteric adenitis, remember, it is normal. They are usually less than 3. Their horizontal, the short diameter is usually less than 10 meters, and that is the reason. So another question is, puberty gets affected in older children with IBDs. Yes, there is a delay in menarche, and there may be some change, but we always look at to it. And once we start treating, then they get their cycles also regularly.
Ma'am, one more, why I got this second case, even though we had lot of severe perianal fistulizing Crohn's and all, delayed puberty, weight loss and all. This is a stage when the general pediatricians might see when it is very mild and when there is you are not sure that this is some sort of functional or some infection. So just to tell them that, yeah, IBD can exist at that stage also. Otherwise, once there is proper constitutional weight loss, joint pains, yeah, then it becomes very easy that, okay, this is organic.
And the subtle signs like this, that colonoscopy beautifully, he showed you those aphthous ulcers, very neat skipped lesions in between. I think it's very important to go a little further into the history. That's what he's always stressing. History, history, history. Even in 2026, AI, everything is there, but history is still very, very important. Someone has asked, one more question has come. Most of the time are due to viral. Yes, it may be due to viral also, someone has asked. Antibiotic for mesenteric. In case you have definite pain, tenderness, and the counts are high, a course of cefixime for 7 days is more than sufficient. Shruti, can we...
Yes, ma'am. Shall we move on to the next case, ma'am?
Yes.
Thank you, Dr. Nagendra, for the wonderful case presentation, and thank you, ma'am, for summarizing it so well. May I request Dr. Vishnu Biradar to present his cases, please?
Yeah, thank you. Nagendra,
Nagendra, you stop sharing.
Stop too.
Yeah. I think I've stopped.
So, yeah.
Sir, I have not taken more than 35 minutes.
No, great, Nagendra. I know. I have taken back my words.
So, the slides are visible?
Yeah. Visible, Vishnu.
So, after 2 wonderful cases, just with what we discussed with Nagendra, and what we wanted is that less of the functional abdominal case discussion and more of organic. And once we know that what organic diseases to look, and once we know clinically if they are not there, then we can definitely say positively that it is functional. So I'm taking 2 cases. which are simple cases, but not so common. The first case one. This is a 13-7-month-old boy. He presented in 2024 with complaint of abdominal pain of 3 months, periumbilical 2 to 3 times in a day, which was lasting just 2-3 seconds with early satiety. And then he started having vomiting once in 4 days, containing yellow to green color, large quantity. But he also had a decreased appetite, weight loss of 12 kg, and he used to wakes up in the night and drinks water also. There was no fever, no loose stool, no abdominal distension, nothing which is no association with the stools. There was no blood in stool. There was no polyphagia or polyuria. No, the history of significant weight loss, but this is there. Family history of allergic rhinitis in mother and father. On examination, child looks normal, per abdomen soft. There was diffuse tenderness, no organomegaly, no rigidity. Air entry was present. So with the history of abdominal pain of 3 months, vomiting, weight loss, decreased appetite, so there has something which is there. So the red flags here was the weight loss which was there and vomiting which was there for a month. So I initially thought, is it a bowel obstruction, upper GI? But history was not suggesting that vomiting was not persistent. It was once in 4 days. I thought because of the weight loss, it could be IBD or it could be a GI tuberculosis. So he was investigated. Hemoglobin was 10.8. The counts were 14,000. And the eosinophil was 35%. Platelet 4.68. ESR was 24. The sugars were 100. CRP was 3.4. He was treated with antihelminthic outside, and then he was referred to the gastroenterologist in the May, where the eosinophil was 21%. So he underwent a endoscopy, and what endoscopic picture has shown is the esophagus. The G junction was normal, but there was some mucosal edema. The pylorus was showing some erosions, and these erosions were like a submucosal hemorrhages. The duodenum also showed some erosive duodenopathy. I had taken the biopsy. Colonoscopy was done. Colonoscopy also showed some submucosal hemorrhage-like and erosions, which were there. So there was a gastric and duodenal erosions, query ulcers, and colonic erosions versus ulcers. And the biopsy showed, duodenal biopsy showed 20 to 25 eosinophils. The gastric biopsy showed more than 30 eosinophils. The sigmoid biopsy showed more than 64 eosinophils. And this child was labeled as eosinophilic gastroenteritis and colitis. And then he was referred to us for the further care. And he was already started on the steroids. So the steroid was started on the 18th of May. Given the course over a period of time, it was stopped. And this was, mind you, this is a 13-year-old boy. Though the milk and milk products were stopped, and the child responded well. Eosinophil was 5%, then 7%, 3%, and 5% in the month of August 2025. So he was doing well for a year. But what happened was in October, he started having abdominal pain again, little bit of loose motion vomiting, which was lasted for 2 days vomiting, responded to symptomatic treatment taken at their hometown. And in September 2025, again, this child started having a severe abdominal pain, which is again a colic in nature, very periumbilical, lasting for just few seconds, no nocturnal symptoms. But he again started having vomiting and weight loss. Again, he lost weight from 54 to 49 kg. We thought maybe a eosinophilic gastroenteritis, the enterocolitis is going into the IBD. So we rescoped him. And this time the eosinophil was 16%. We did the IG, which was 858. ESR CRP was normal, which was very surprising to us that in spite of this weight loss and everything, he was normal. And we did the endoscopy, and what we found in the first picture, you can see on the left side, there was a big ulcer in the esophagus, and these kind of ulcers were there in the esophagus, in the middle and the lower esophageal part. There was a erosions, erosive esophagitis was there. Pylorus and the stomach was also showing some erosions. And there was a surprisingly small diverticuli in the antrum, and the duodenum also showing the erosions. Though this time the colonoscopy was normal, including the ileoscopy. As was discussed just before, the fecal calprotectin was done, which was negative here. We thought of eosinophilic, so we wanted to rule out the collagen. So ANA by IF was done, which was negative. Albumin was normal. The TTG-IgA was negative. IgA was normal. Urine routine was normal. LDH was 374. But with this, we were unable to explain the abdominal pain. The symptoms, the major disease was there in the esophagus. There was erosion in the stomach and the duodenum. But his disease was something which was, we are not getting the explanation. And there was a diverticula in the stomach. So we did plan for CT angiography, which showed diffuse wall thickening in the stomach with up to 12.7 millimeter in the pylorus. A small gastric diverticula with a neck of 7 to 8 mm. The jejunal loops were dilated up to 33 millimeter. There is a diffuse circumferential thickening involving second, third, and fourth part of duodenum, jejunal loops. There was a mild circumferential wall thickening of IC junction. There was mild to moderate ascites. There were lymph nodes of size of 20 to 14 mm, and there was mild splenomegaly. And he was incidentally detected to have a spina bifida also. So we were not sure what we are dealing with. This is not IBD for sure, but what it could be. So we were thinking eosinophilia with pain, with weight loss. So am I dealing with some kind of myeloproliferative disorders or lymphoma? So we went ahead with the PET scan, which also showed the similar finding of gastric wall thickening with FDG activity, and in the small intestine also, and mesenteric lymph nodes. Also, there was a lymphadenopathy in the chest, which was not having the SUV max was around 4 or 5, so not suggestive of any lymphoma. So we treated him as a relapse of eosinophilic enterocolitis. Second cycle of steroid was given, and slowly the steroids were tapered over a period of 3 months. And he started gaining weight and the symptoms disappeared. And again, after stoppage of the steroid, he started having the same symptoms: vomiting, pain in abdomen, and little bit of loose motion, and weight loss of 5 kg. So we took the help of hemato-oncologist and we did the bone marrow aspiration. This time the eosinophil count went up to 49%, and absolute eosinophil count was 15,000. So we were very sure that this is eosinophilic, some kind of leukemia or myeloproliferative disorder. We did the bone marrow. We just showed eosinophilia and some blast, but there was no evidence of any myeloproliferative disorders. And chromogranin A was normal. But because of so much of high eosinophil count, we also tested for brain and the heart. And what we found was, in the heart, there was a myocarditis involvement was there. So we were clueless at this junction what we are dealing with: relapse of eosinophilic enterocolitis. Frankly speaking, whenever we see eosinophilic enterocolitis, we treat with anti-helminthic, anti-worm infestations medicines, and some modulators like steroids, and they don't relapse later on with the good care. But here there was a 3 relapses which were happening. So we sent whole exome sequencing, thinking about that we will have the mutation of myeloproliferative disorders like FDG or flip disorders are there. But surprising, the report came as a PSMB10 mutation, which is a deletion missense variant mutation, which is consistent with immunodeficiency 121 with autoinflammation, and there they have the eosinophilia as a predominant feature. So this child was referred to hemato-oncologist for now bone marrow transplant. So in general, when we see eosinophilic esophagitis, which is usually seen in the infants, we do come across patients with eosinophilic esophagitis, where we treat with PPI, swallowed topical corticosteroid, sometimes amino acid-based formulas, And very rarely we get older child with eosinophilic esophagitis, where we have used monoclonal antibodies like dapilizumab. We rarely come across eosinophilic enterocolitis, but there they respond to steroids and elimination diet. So there are elimination diets, something called as a mono elimination diet, or you do go for a blind. So you have to avoid the milk, egg, fish, prawns, and nuts. So these are the five commonest food items which can give rise to eosinophilic. We do see patients coming from the coastal areas or who went for a vacation there, eat fish or prawns there, seafood, comes back and they started having the abdominal symptoms for a few months. When we scope them, we see the eosinophils, but given the treatment for a short course of steroids, and they don't do relapses like this child. So this is something which is, and this was recently diagnosed child. So a plain periumbilical abdominal pain, which was just lasting for a few seconds, can go like this with some rarer causes. So right now the child is showing eosinophil of 2%. This was latest on the 9th of February, and he was on the tapering dose of steroids and the PPI. So here I wanted to stop and have some comments or some discussion, any questions, and Malti madam's comments.
Dr. Vishnu, I think you presented a very interesting case. This spectrum of now eosinophilic gastrointestinal disorders is now coming up in a big way. Under that, we see eosinophilic esophagitis separately, and we seem to understand about its pathogenesis little better than we understand the rest of the esophagus involvement, because that can involve any layer, the mucosa, the muscle, as well as the serosa. And this type of presentation, beautifully, he showed that, in our country, especially, eosinophils can be seen in the colon. It can be. So everywhere there is a cutoff. And only when it is more than 15 per high power field in the esophagus, we call it eosinophilic esophagitis. It is different between the right side of the colon, left side of the colon. He's made that. So as pediatricians, what will you think of when the child has abdominal pain, vomiting with weight loss? He gave a differential diagnosis. Definitely one, intestinal TB, second, IBD, especially small bowel Crohn's, he was thinking about. Third, he was thinking about lymphoma. Fourth, he was thinking about EGID. Fifth, he was thinking about, we now see C-Muse also. C-Muse is another fifth one, but we don't want to discuss it with the pediatrician because it becomes a specialist. But I think in this child, imaging should have done higher, because from the beginning, it looked like a small bowel involvement. So for you, I think we should not err in doing CT thinking it's radiation, because you will pick up. You will see the map. You would have seen the thickened jejunum. You would have given a different clue. No nodes, but thickened jejunum. That means there's no lymphoma. If there had been nodes and jejunum thickening, like if it had been, sometimes we just say, okay, do a DLAP and do a full thickness biopsy and get it. If you're not able to get it, because you can't keep on giving steroids. But I think beautifully, now we also have enteroscopy, double balloon, where we can go to those lesions, even jejunum. And I think Dr. Vishnu, he's excellent now in the endoscopies. He can take his colonoscopy even right through the ileum and go up higher up and take a biopsy. So I think those two we would have done little more. Capsule will help us, but sometimes we are careful. But I think a double balloon enteroscopy, we don't stop short at duodenum and stop at ileum. We go right across, take the biopsy, and then get the thing. And then this genetics and immune, I think, will be the in thing for all the pediatricians. Finally, we learn more. But I think beautifully you showed that eosinophil. So the DD for a child with abdominal pain, vomiting with weight loss, in a 13-year-old, unlikely to be in the stomach, but it will be a little lower down. Always think of upper jejunal involvement. Jejunal is the one which is missed. I think even Dr. Nirmala will agree. Isolated jejunal we are seeing now of Crohn's disease presenting like this. I think beautiful DD, very nice case, Vishnu. Unless the someone has some questions, otherwise we can go to the next case. Someone wanted to know, we do elimination diet more for eosinophilic esophagitis. We have two FEDs, Then we have 4 FED, 6, but like he said, the major allergens, those are the ones we exclude. Why we do it 2 by 2 is so that you can introduce, if they are okay, then after 2 weeks you introduce, but give some time before you introduce anything. We can even give 4 weeks time between introduction of a new allergen, because the response, this memory in our body is very, 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 very sensitive. It's very sensitive, and we don't want them to go down their thing. So if they're improving, continue, wait for a minimum 2 to 4 weeks, and then introduce the second one. I think that was the question for you, Vishnu.
Yes.
Unless you have
So
something to say.
yeah. First time it was done by the adult gastro, and they did the biopsy, started steroid, and then sent back to me to for the tapering and the further management. So it was already started the management. So
So
that
this is
time
the
we couldn't
problem. No, when you
introduce.
give steroids, everything becomes different.
Yes.
The eosinophil count comes down, your diagnosis difference, and especially when there is a malignancy. Yeah.
I think Dr. Vishnu, by now it is immune dysregulation, which is leading to
Yes.
hypereosinophilia. At
Yeah.
this moment, because I can see some questions, how long to continue elimination diet? I don't think so. There is any role of elimination diet at this
Elimination
point.
diet in this. Yeah.
I think
Now it is very classical case of that immunodeficiency with
immunodeficiency 1, 2.
eosinophilia. This is
Yes.
called as a autoinflammatory syndromes. I
Yes.
have couple of patients of autoinflammatory syndromes in the infancy, but this is the
Yes.
first
Yes.
case which is in the adolescent age
Yeah.
Yeah,
group.
I think
It's
the
very
spectrum
surprising
of
at this stage.
autoimmune and autoinflammatory is now becoming the in
Yes.
thing.
So we
Inborn
have STAT
errors of
mutations, we
immunity.
have the FDG mutations, we had the SPINK mutations, which is coming with autoinflammatory
Yeah.
syndromes. We have this NLPR mutation 1 and 3. We have NLPR 2 with the eosinophilia and the hyperinflammation and the colitis-like picture in the infancy. So
So for
these
the
disorders
pediatrics, I
are
think they should know this autoinflammatory syndromes. No, they don't
yeah,
do well when they get Kawasaki, when they get
Kawasaki.
COVID. So that is the
Yeah,
thing, I think, because
yeah,
genetics, none of us can understand, and you get it later. But why is
yes,
this child not improving? Then you find
improvement.
it's a spectrum. They are not,
Yes, ma'am.
they'll get that.
Yes, ma'am.
Very nice case,
Will
Vishnu.
Yeah. Yeah.
you go to next case, Vishnu?
Yes, thank you, madam. Thank you, everybody. So coming to the most common presentation, 15-year-old boy, abdominal pain of 3 months, acute pain, severe. He was not able to walk or change the position, and he says sometimes from minutes to hours it is lasting, but there was no nocturnal awakening, and there was some altered bowel habits, skipping the stool, irregular stool, but sometimes loose stool, what he was telling, but it was not associated with abdominal pain. Otherwise child was normal, physical examination was normal, weight 59 kg, height 147 centimeter, and this was the anxious looking child. I have to take the parents also. The father was like him only, the very anxious child. He was not able to walk. He was not able to sit while sitting. Also very slow, and again he was, whenever he was changing position, he was saying it is paining, 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 very severe pain, and he was continuously in the pain. So this is what the story of Nagendra, me, Malti madam, every day you get such a kind of patients. So the differentials which we usually see as a pediatricians, as a clinician, that whenever the child is not able to walk or something, then we think about any peritonitis, any enteritis, is the child having appendicitis, uretary colic, intestinal obstruction, or a FAP-NOS. So what I did all the tests, because parents were anxious, they were roaming around, they were admitted twice outside and came with this, not ready to listen that this is something which is not organic. So we did all the battery which is there, the routine test, hemogram, TSR, CRP, X-ray abdomen standing, ultrasound, urine routine, amylase lipase, everything is normal. So what next? So what I do personally is that what kind of pain this child had. So what Nagendra has shown is the right hand lower corner. Severe, intense, episodic pain associated with nausea, vomiting, sometimes headache, phobia, we say it is a cyclical, we say it is an abdominal migraine, so which is a stereotypical pain. Okay. The second was vague pain, but associated with constipation or diarrhea. We say irritable bowel syndrome, either a constipation predominant or a diarrhea predominant. If it is a epigastric pain, what the Dr. Nagendra has shown the first case, epigastric pain after eating food, early satiety and bloating, we say it is a epigastric pain syndrome, the functional dyspepsia syndrome. And when it is not fitting all in these three categories, then it is called as a continuous, episodic, umbilical, midline, daily, but no nocturnal pain, not associated with food or bowel. We call it functional abdominal pain and not otherwise specified. So this is the 4 different categories of functional abdominal pain. Whenever the child comes to us, we should divide them that what category they are fitting into. And once you fit into that category, either label as functional dyspepsia, IBS, constipation or diarrhea predominant, abdominal migraine, or your FAP-NOS. Once you label that, then you try to differentiate from the organic and functional. So organic is acute, persistent, sharp, awakening child from the sleep. And as madam told that it is away from the umbilicus and usually associated with fever, anorexia, weight loss, or diarrhea. Functional pain fluctuates. It is vague pain. There is no effect on the sleep. If you ask them, once the child sleeps, he will never wake up in the middle of the night. He will wake up in the morning, and then once he wake up, then he starts saying pain, 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 pain. So there is no nocturnal awakening because of the pain. And usually it is at umbilicus or epigastric, and it could be with the multiple episodes, multiple places, sometimes different places he gets pain. So if I make them a syndromic or in a compartment, so if it is a functional dyspepsia kind of pain, so what things I should rule out? I should be ruling out the GERD or acid peptic disease. I should be ruling out the pancreatitis or a cholelithiasis or more choledocholithiasis. If it is a IBS with constipation or diarrhea predominant, then I should be looking at hypothyroidism, IBDs, or celiac. If it is an abdominal migraine kind of pain, then I should rule out what organic causes, malrotation, biliary colic pain, renal colic pain, sometimes porphyria. And if it is not fitting here, then it is a functional pain, functional abdominal pain. And here, sometimes you get a lead poisoning as a cause of functional abdominal, this kind of pain as a cause as a lead poisoning should be ruled out. So what I do is I do as a step 1, distinguish between the functional and organic. Then the pattern recognition, what we just went through in 3-4 slides. And then on that pattern evaluation, I do the structural evaluation that I should not miss that. And then I make a customized management plan. So I do a positive diagnosis that when I know, I tell parents that I am looking at a benign nature of disease, is not having serious disease. And usually when we discuss them, calm them down, show them the growth chart, tell them that there are no red flags which I am looking at, they usually get convinced that, okay, my child is not having some disease. But I always ask 2 questions, and I think this is what I learned from the Rome 4 criteria and the people who are looking at the functional abdominal pain. Is there any history of sexual abuse? I always ask this question, and I always ask what are the any psychological issues in the family. May not be in the first instance, in the first visit, maybe in the second visit when I gain the confidence of the parents. But mind you, with this, I have done justice to few of the kids where we have made FIR cases, we filed the cases, we have find out that who was the culprit. Sometimes it was in the school, sometimes in the family. So you need to ask these positive questions. And many times we have seen that psychological issues with the parents. Parents are themselves are going through some turbulence. Some may have lost the job. Some may have had some health at home, which is their financial has gone very. There are issues in the couple, the wife and husband. There are problems. There are problems in the family. Disputes are going on, or there are pressures which are there in the neighbor, or something is there in the family. And many a times, one of the parents is also having some anxiety issues. Even we got a patient where the father was himself in the 3 months care for his anxiety issues, and mother was also having the anxiety issue. So they themselves may be going through some psychological trauma. So it requires a team approach, multidisciplinary. We need to discuss with the pediatrician. We need to take the help of child psychologist. We need to ask them to bring the parents, the grandparents, or immediate family members which are they are close to, so that we discuss that amongst themselves and understand what problems they are going through. But what is the treatment which I should be doing? If I am 100% sure that it is a functional abdominal pain, so this is the cognitive behavioral therapy is the only therapy which will help. They will able to find out what really is causing stress in this child. Sometimes there is a math problem. Sometimes there is a peer pressures. Sometimes there is bullying in the school. They will not tell this to the parents or to us. So the child psychologist will take care of them. And then there is a behavioral modification or rational motive techniques. What they do. Sometimes mindful breathing. One of the child was very brilliant in drawing the arts. So what psychologists had said that whenever you get pain, go and sit and draw something. So there is a what we call deviation, or we deviate from the pain to their whatever their interest is there. So this is how this cognitive behavioral therapy works. So at in brief, when we get patients with functional dyspepsia, we treat with PPI and prokinetic for 2 weeks to 4 weeks duration. When we get a patient with IBS with constipation, we treat constipation. If there is diarrhea, then maybe we use some anti-motility drugs. When there is abdominal migraine, after ruling out all the other causes, then we take the help of certain medications like propranolol or ciprofloxacin, or sometimes going up in the ladder like valproate. When we see functional abdominal pain not otherwise specified, so first line is cognitive behavioral therapy, and sometimes we take the help of drugs like amitriptyline and ciprofloxacin. This is how I treat functional abdominal pain. But for you, when to refer this functional abdominal pain to pediatrician? When there is a treatment failure, prolonged stool abscess, presence of red flag signs like localized pain away from the umbilical, very, very important. Nocturnal symptoms, very important. Document weight and height on the growth charts. Growth failure is there or not. If there is any delayed puberty, is there any perianal disease is there or not? You have to see organomegaly and document there are no abnormal laboratory tests. Like if you have elevated ESR CRP, thrombocytosis, anemia, needs workup, then you need to get help of pediatric gastroenterologist. And the low albumin is there, a persistent or stool local blood positive, or a positive celiac serology, definitely you need to refer them to pediatrician. This is in nutshell about the functional abdominal pain in children. Thank you.
Thank you, Dr. Vishnu, for taking us through functional abdominal pain, still an enigma for all of us. And I think for the pediatricians also, it is that's why they wanted this. So now we are able to tell, because the question again will come from the parent. If everything is normal, why pain again? That is the question. Everything you've done is normal, then why pain? The child is also asking, oh, this doctor is not good. Everything is normal, then why pain? So I think the simple way to tell the parent, I tell the child, you have a big brain here, but you have lots of brain in your intestine. The more you have brains, the more pain you will have. So first thing, try, and then he'll smile. That's the first thing you should tell, because we know it is disorder of gut-brain interaction. But why my child? Again, they are going to ask you. So the only thing is, now we know, we are able to explain to them, what is that gut brain? Why is it acting? It is because it's bidirectionally connected. It can respond to physiological stimulus, it can allergy, it can respond to noise, it can respond to anything by just visceral hypersensitivity. So I'll tell them, see, some children, you just touch like this, they will scream. Some what is this pain? So I said that response, visceral hypersensitivity, visceral motility, their response, the body, and then the intestines, they know very well. This little brain is sharper. 1 million little brain he's got. And that will immediately send impulses to the big brain. And the big brain will open the gates and then again send the pain. So all that he's saying is normal. Most important is don't use the word they are malignating. It is pain. Understand that pain. And I think beautifully Vishnu said, if he has pain in the epigastrium, you have to, yes, do reassurance, but you may have to treat it. Constipation in our country triggers the pain. And don't think all these are watertight compartments. And a child with organic can have a functional pain. A functional child can have an organic pain. And this history, talking to the child alone. First, try to get, best friend for that child. The child will not open up on the first day. It will be watching how you are talking, how we are talking. If he thinks we are on his side, he will slowly open up. Otherwise, they will just have to keep running around. I think this disorder of gut-brain interaction, or very simple brain, little brain and the big brain, if you can tell them that it's a brain-gut disequilibrium. Today also some doctors asking how, we know butterflies in our stomach, we are saying gut feeling in our stomach. We didn't realize intestine has so much feeling. It has lot of feeling. I think that feeling, and yesterday one boy saying, what to do? You have so much of brain here. You had so much, God did not know where to put it, then put everything in your intestine. That's all. He started laughing. See, somehow we have to become their best friend. Many reasons may be there. That reason will not come on the first day. Second day, it might not come. Third day, the whole problem will be with their father, with their mother. So sometimes it will become very delicate, like Dr. Vishnu was saying. The family will be there. You'll have to manage both. You have to manage everything. Nowadays, what all we hear, we've never heard that before. Stories which we are hearing, we've not heard that before. So it is going to be very difficult, and all that we need is patience. If you are very busy with your practice, give them another appointment, ask them to come, because it will take nearly 45 minutes for functional abdominal pain. Easily you'll make a diagnosis of appendicitis, pancreatitis, all that you can make. This functional abdominal pain and making them well. Reassurance, yes, but along with that, you have to understand the problem. Thank you all for hearing, and I think both of them did an excellent job, took you through abdominal pain beautifully. Night show, remembering all the movies we used to see. Empathy is the need of the hour. Yes, doctor, and the time we give them. Very nice. I think Nirmala will say a few words. Shruti, you want to say something? Shruti, you want to...
I just wanted to thank Dr. Vishnu Biradar for the two wonderful cases. The first one was nothing less than a Hollywood suspense story. We were really curious to know the ending. And second one was nothing less than a Bollywood drama. Thank you. Thank you so much for the wonderful case presentation, sir.
Shruti, there are a few questions in the box. Shruti?
Yes, ma'am. Since we have few minutes, shall we just quickly go through
Yes, please. Yes.
Okay. Dr. Nagesh wants to know how common is H. pylori gastritis in pediatric age group and any clues for diagnosis?
H. pylori, I think we've written a recent paper also. Like we said, H. pylori is an infection of childhood and disease in older. I think that all of us should remember. And we don't treat infection, we only treat the disease. It's very important. But if the child has, like Dr. Vishnu is saying, epigastric pain related to food, a dyspepsia, we definitely do an endoscopy. It may be epigastric pain syndrome, but if along with that, if there's a bleed, if there's a loss of weight, child is not able to eat, we do. But we have to know using serology, know doing fecal and antigen and treating. Endoscopy, direct method, 2 tests should be positive, both RUT and the biopsy. If there is a DU, GU, family history of gastric cancer, maltoma, we will treat. But if there is nodularity of the stomach, then we take a biopsy, document H. pylori as well, because now we are seeing treatment unnecessarily is getting more drug resistance. We are getting more infections which are all resistant to drugs, and unnecessary treatment also. So I think Vishnu will agree to that, that epigastric pain, you're not going to do
Yes, ma'am.
endoscopy for
Yes.
a lower abdominal pain, not for just isolated periumbilical pain. We will do it only there. And then we have to document. Please don't do breath test, don't do stool antigen and then treat. Already we are
Yes.
landing up with problems with H. pylori resistance in our country. It will be positive. In our country, children will be positive. Infection, disease is what you have to treat.
Yes.
Rightly mentioned. I don't think we have any more questions. I think somebody has mentioned that in case of pain abdomen, abdominal wall disorders should also be kept in mind, like small
Absolutely,
intestine, other
absolutely.
causes.
Particularly the umbilical hernia is getting obstructed, particularly with the small fat, so small of the bowel wall. So umbilical hernias are known to present with abdominal pain, and you should be cautious. And there also the child will not move. So I have a couple of patients which are obstructed umbilical hernias with the small fat.
Yeah, I do have so many times this small momentum or something will prolapse into that, and then that keeps causing the pain.
Correct.
Very localized pain, but
Localized.
yeah.
Any more questions?
No,
from
no
it?
questions. Actually, Nirmala has to speak now. Yeah. Nirmala ma'am. Yeah.
Yes. Very, very well presented by two speakers. Very good cases. I'm insisting on the presence of red flag signs. The first case, pancreatitis case by Dr. Nagendra. We know that in younger children, the abdominal pain is not predominant in pancreatitis, more of vomiting. But in the older age group, the abdominal pain is a predominant symptom in pancreatitis. Only thing, even such cases, we will have some growth faltering or there will be a loss of weight, something like that in pancreatitis. Very rarely they come without any red flag signs, and this is a very, very different case. The second case what Nagendra presented, very rarely the IBD, abdominal pain and growth faltering are the cardinal symptom and signs of IBD. Very rarely it will present without any growth starting, but we have seen such cases also. But always we have to be cautious, and you think that it's not going the line expected, you always prefer to do a endoscopy or something to get to the diagnosis. But both the cases are very, very good based on the high degree of suspicion. He has diagnosed both the cases and has done appropriate treatment. As far as Vishnu's cases goes, it's a very, very difficult case. I know even we have had such cases nowadays, more and more cases where which doesn't fit into any other case finally lands up into an autoimmune case or something related to immune dysregulation. Very common now because now we have started doing lot of this genetics. We have seen lot more of such cases. Very difficult to treat because at least if you have a BMT or if BMT can be curative, it's okay. But some cases it's not even curative. It's very, very difficult such cases to go about such cases. Very difficult. And this presenting as abdominal pain is very, very difficult in such cases. Then very, very good approach by Vishnu is how you approach a case of abdominal pain, dividing them into various types and based on them rule out all the organic causes and then go about treating them. Very, very, very good approach, Vishnu. It has been very excellent approach by you. How to approach that. And this is very, very important because unless you know that what are the usual symptoms and what are the organic causes can cause similar findings, very, very important. You should know whenever it's not getting treated by the usual ways, then you have to think of something organic. Very, very good. And please understand that functional abdominal pain is a positive diagnosis, and more cases will be coming, and that will be more than the organic cases, and you need a lot of patients to treat them, and most of them you may need an help of a psychologist or a psychiatrist to help you out with these cases. And so all four cases are very, very important cases, and both of them are given their idea of how to approach the case of abdominal pain, and which will be very, very useful for people who have been waiting for so long to listen to all of you. Thank you for the opportunity. Thank you.
Thank you.
Thank you.
Thank you.
The third case is eosinophilic esophagitis. Vishnu.
Enterocolitis, yes, sir.
Enterocolitis.
So, okay.
But it is more of not a primary eosinophilic. This one, it is more of immune dysregulation. Yeah, because the standard eosinophilic esophagitis or gastroenteritis does respond very well, like Dr. Vishnu said, with one course of steroids, with elimination diet and all these things. But here it was very malignant course, like again and again it was coming up.
And because
Correct.
of the myocarditis, we have to pulse them with 30 mg per kg.
Yes,
Otherwise,
yes.
they will be having the difficulty in the heart.
It's more of immunological
Yeah,
disorder.
That diffuse infiltration is a clue that it is more systemic
Yes,
Yes.
yes.
rather than pure GI
With ascites, yeah.
with ascites.
It's ascites,
Yeah.
yeah.
The ascites fluid didn't give any clues. Ascitic fluid.
We did not tap it that time.
Okay.
Okay.
Thank
I
you,
think
everyone.
Shruti, we can close it. Yeah, yeah.
May I request
more.
Dr. Kushal to
Yes,
just
madam.
give some concluding
Yes,
remarks?
madam. Thank you for the wonderful session. I thank our chief guest, our expert, and our speakers, especially Dr. Nagendra, my very good friend, for an excellent presentation. And I thank our EB members, Dr. Priya Shivalli, Rajendra from Tamil Nadu, and other seniors, Dr. Nagesh Kamath sir, and Sarala madam, Yogesh Parekh sir, our national secretary, our Raghuramaya sir, Nandish, our program coordinator, and thanks to all those who have attended.
Raghunath,
Dr. Raghunath,
IAP Bangalore President, Raghunath.
IAP Bangalore President, Rupaman Shetty Madam, Anthony Roberts, Sudhakar from Tamil Nadu, Parinita, Major Abhijit, Sarika Prasad from Mysuru, Sahana Devdas, our EB, and Sunil Kumar, our Secretary of Karnataka, Geeta Patil Madam, and all others who have attended. Thank you very much for the wonderful session and good attendance. Thank you very much.
Thank you. Good night. Good
Thank
night.
you. Thank you,
The
Dr.
program
Nagendra.
had
Thank you,
almost
Vishnu.
more than 90 attendees, which was
Yes.
very good
Yes.
to see.
Thank you, Dr. Nirmala. Thank you, Dr.
Thank you,
Excellent.
Malati
madam.
ma'am.
Thank you, everyone.
Thank you.
Thank
This
you.
hour.
Thank
Thank
you so
you.
much. Thank you so much.
Thank you.
Thank you,
Sir.
Thank you,
Nagendra.
Malati madam.
Thank
Thank
you,
you.
everyone.
Bye. Good night. Good night.
Good night.
Good night.
Good night.